Back in 1954, something extraordinary happened in Boston. The first successful kidney transplant between identical twins. Now, that moment launched a whole new era in medicine. So, fast forward 70 years, and kidney transplantation has become routine. In fact, there are about 27,000 performed each year, and that's just in the United States. But the need is still great. There's over 90,000 people who are still on the waiting list. The field has come a long way, thanks in many parts to the leaps in immunology and infection control. But none of that progress would have happened by chance. It really is the result of decades of work by scientists, researchers, clinicians, pushing the boundaries of what is possible. And one of those trailblazers is our guest today, Dr. Robert Montgomery. He is the chief of transplantation at NYU Medical Center. He is a giant in the field, literally and figuratively. Yes, he's over 6 feet 1 inches tall. And yes, he made headlines by transplanting a pig kidney into a human. But what really sets him apart is that he knows this world not just as a surgeon, but as a patient. Dr. Montgomery is alive today because of a heart transplant. In a powerful twist of fate, in many ways, the very science he's helped move forward ended up saving his own life. We were supposed to talk with Dr. Montgomery a few weeks ago, but he had a good excuse for rescheduling. He had just been named to the Time 100 list. And alongside his medical work in the United States, he has traveled to the Ukraine to provide care during this war. He's been there multiple times and was honored by the country's president for his efforts. Dr. Montgomery, you've had an amazing story. So I thought we could start a little about your journey, but your path to becoming a transplant surgeon, and then we'll get back to being a transplant recipient. But maybe you could tell us a little bit about being the surgeon.
Sure. So, my identity as a surgeon and a physician is intertwined with my identity as a patient, actually. So, I found out when I was an intern at Johns Hopkins, when one of my brothers, dropped dead at age 35, that our family had a genetic disorder that's called dilated cardiomyopathy. And that, obviously really had a dramatic impact on me personally, on my career. Initially, actually, after, it was determined that my brother had died from the same disease as my father, and he was 52, my dad, when he passed from cardiomyopathy. I got on a treadmill, and at the peak of my exercise, I had ventricular tachycardia, which is a really dangerous arrhythmia. And they told me I had to have a defibrillator placed, which had really just very recently been invented at Hopkins. And they had never implanted one of these early, defibrillators into a surgeon before. And they really felt that it wasn't consistent or compatible with me becoming a surgeon, and really told me that it would be best for me to look for another career. But I am a bit tenacious, and I also had a really good mentor who held my position in the residency when I went over to Oxford, and that had been planned even before I found out about this, to go and do a PhD during my residency in immunology. And Dr. Cameron, who was my chief at the time, said, well, we'll see, how you are when you come back. And believe it or not, what I ended up having to do, because they were afraid that the electric cautery that we use in the operating room would trigger the device to go off. This is a huge deal back then. Had to be implanted in my abdomen. It was the size of a Coke can. They had to split my chest open and put capacitors around my heart. So it's not the little tiny device that, you're familiar with these days. It was, potentially career ending for sure. So I went to the EP lab and tested all these devices, and it didn't make it go off. And then I carried on. They let me finish my training, and here I am, 40 years later.
So back to the Hopkins days, then you had this device in and you're practicing surgery at that time.
Yes.
How'd your colleagues think about that?
Yeah, so yeah, it's a good question. I'm sure there was a lot of talk initially about, is this the right thing? Because obviously the device is there. It just sits there and watches the heart, from beat to beat. And if I were to develop a dangerous arrhythmia, it would deliver a shock. Though those shocks are not subtle. It's like getting hit in the chest with a 2x4. It never ever happened in the operating room. And in fact, what I had to do really is to change the way I thought, because the device did go off soon uh, after I was in Oxford, trying to extricate a baby from a overturned car that I just happened upon, who was unconscious, and just the adrenaline surge caused the device to go off. So I had to learn how to completely eliminate adrenaline from my life and really rethink my inner voice and how I approach life. Complete reset.
And
And with that, no matter what happened in the operating room, I wasn't going to, get to that point where the device could go off.
well, not a good situation to have it going off in the operating room, but you're doing transplant surgery and catecholamine, your adrenaline's always going to be kicking there on a regular basis. So you have to sort of basically get your mind to just calm down. How do you do that? I mean,
Yeah, so I did.
everyone would like to know how you did that.
I know. Well, it was a slow process that took place over a couple of years. Again, when I was doing laboratory work, and every time I approached, a situation where I might have become activated a bit, I would sort of kind of using biofeedback and talking to myself, just prevent that, and then it became just part of my physiology, and after that, I really didn't have to much focus on it. It was like muscle memory, for my body. Can be done. People do it through meditation. There are different ways, I think, to achieve that sort of state. I did it just really on my own and just redid the way I thought. Um, I've almost completely um, eliminated that voice in our head that is sometimes so limiting, and it is very critical. So it worked out. It's hard to explain, but I was able to do it, and that's, I think, what saved my career.
So you have the this device in which shocks you if you have a problem. And I guess for the audience, I'll just mention like cardiomyopathy, just so everyone knows, is a condition where your heart muscle starts to fail, and over time your heart doesn't pump as well, so that the organs, the rest of your body, doesn't get enough oxygen basically to do the jobs it's supposed to do. Just for so that it's not two doctors just having a conversation here about
Sure.
things. And so you have the device in, and now you are doing your surgery, and then you traveled off, right? You continue to live your life, and what happened when you traveled? I mean, were you worried? Because obviously at one point that became an issue, right?
Yeah, so how I describe like the next 30 years of my life was that it was long periods of stability punctuated by near-death experiences. And those experiences were mostly associated with, intense physical, um, exercise. Or the first time my device went off, I was 50 years old, and I was in Patagonia, and I was climbing a mountain. I'm an outdoors person, in the middle of a snowstorm, and it went off. I lost consciousness, and the device went off, saved my life. Over the next 10 years, then, or 8 years, it I had six other cardiac arrests, and one time I just happened to be in a Broadway show, and it was sort of getting toward the point where now, the heart was failing, and the electrical instability was worsening. And I was just in this, a Broadway show with very loud music, and got triggered, and then the device didn't wasn't able to convert my heart. So I had like 40 minutes of CPR. There just happened to be a doctor and a nurse nearby,
Lucky,
and very
lucky.
lucky. I mean, the chances of surviving something like that is probably less than 5% outside of the hospital. Um, and then, the ultimately I was in a place in Italy, where it was a medical convention, a very small town, and I had what's called ventricular tachycardic storm, where I had one cardiac arrest after another. They took me to this little hospital, and the first person I saw when I came through the emergency room was a priest who gave me the last rites, which I
That's
thought
not a
was
good sign.
it's not a good sign, but I also thought it was kind of pessimistic. But anyway, I was able to get stabilized, and then one of my friends who was at the meeting flew back from Rome, and I said, look, I think now I'm actually sick enough to get listed for a heart transplant. And that's what I think this story really punctuates, is the fact that because the allocation of organs, and in particular hearts, um, is based on severity of illness, you have to get so close to dying in order to really be in the running for an organ. Organs are so rationed, and so that when I signed out against medical advice. They wanted to keep me there for a month. I didn't even tell you the story in Patagonia, where I was in a coma for a month after cardiac arrest. Um, but I wasn't going to have that happen again. And I knew now that I could probably, get listed and get in an ICU, with that diagnosis of VT storm. And so they gave my friend a bundle of resuscitation medications, and left my IVs in, and I got on a Lufthansa flight and flew back, and checked into the ICU and got listed for a heart.
I'm glad. You know how they sometimes call for a doctor on the airplane? Well,
Yeah,
you brought your doctor along, but
brought
you're
my
not the
doctor with me.
exact. So you just flew back on a commercial flight. You weren't worried about
Yeah, I
something
mean,
happening.
that's at that point. I just wanted to get back as quickly as possible, and they had sort of stabilized that condition, and I was confident that I would be okay, and it was the quickest way back. So that's what we did.
So Argentina, Broadway, Italy, a little bit like the dramatic, very much as dramatic. Uh,
Yeah, it was it was extraordinary and ugly, and all of that, but somehow, I passed through that gauntlet. Um, and then I received a heart transplant a month later. Was in the ICU for that month, and the only reason that I received that heart, I would have, because of my size, I would have probably waited a long time and might well have died. Only a third of the people who get listed ever get an organ, and only 10% of the people with organ failure ever get listed. So when you think about it, it's really unlikely to get a transplant the way the things are right now. And so I got an organ from somebody who had a drug overdose, a fentanyl overdose, and had hepatitis C. And I got hepatitis C, but now we had these new drugs, and I was part of actually my own clinical trial that we had started at Hopkins and then brought to NYU, and that trial, I think, probably saved my life. Um, and but again, it really underscores just how precarious a situation people with organ failure are in. And it, you know, when I woke up from my transplant, I really, it was so clear in my mind that the rest of my life was going to, whatever that was going to be dedicated to finding another source of organs, um, to, to try to address this terrible crisis we have in organ supply.
So that was part of your research in the sense of looking at using donors who are not necessarily, a relative or somebody that matches. So in many ways, that's what ended up saving you because of the research you were doing, which was
Yeah,
what that was back at Hopkins, or was that at
yeah.
NYU?
So
So you took it along with you.
we did a small trial at Hopkins because the direct acting antivirals, these new drugs that were highly effective at treating hepatitis C in people who had hepatitis C, um, were showing such great promise, but no one had ever given them to somebody who was immunosuppressed and was receiving a transplant. And no one had purposely ever given an infected organ to someone, right? So this violated, a lot of common sense. And but it worked. It worked in those first 10 patients. And I figured, well, look, if I'm asking my patients to do this, I should be willing to do it. In fact, I should set an example because I think that's what leaders do, right?
Absolutely, absolutely. A question I have. So now you have this transplant, and shortly after that, COVID happens, and even before COVID, you're working in a hospital where there's all these bugs, which everyone says, the last place to be when is a hospital if you want to prevent yourself from getting sick with some bug. But here you are, you
Yeah.
put yourself right in there, and then you put yourself right in there during COVID. Tell us a little bit about what that was like and how you felt, particularly early on with COVID.
Yeah, well, Howard, I'm kind of hard to kill.
Yeah,
So there is
nine
that.
lives.
Although I think I've used up quite a few of them. But anyway, COVID was really something because you're right. We had over 500 transplant patients in New York who died of COVID. And so the immunosuppressed patients, were really at significant risk. Um, I had to carry on. I felt like, I was fortunate. I was among the first wave of people who were eligible for the vaccine. Now, I may have been the first person in the world to get a third dose of the vaccine because I was enrolled in one of my colleagues' studies, looking at antibody responses to the vaccine. And I got it. And a few weeks later, they checked my antibody, and I didn't have any response to the first two doses. The hospital was concerned about me and taking care of patients and said, okay, why don't we try a third dose? And I got a third dose and I got a response. And that's how that all started, really. It was through, Dori Segev, who I think
I
who
do.
was running this incredible clinical trial that was all virtual. He would have people get the vaccine and then send these little devices that drew a little bit of blood out of people's arms, and he ran this huge trial on immunosuppressed patients, and that's how we learned a lot about, you know, responses to vaccines and immunosuppressed. Anyway, it was frightening in the beginning. Of course, the people were, people don't realize. I've often said that there wouldn't have been any doubters or skeptics if we had allowed, the media to go into our ICUs during those first 2 months, um, of 2020, because it was just unbelievable what was happening.
It,
Um, Go ahead.
and I would say it seems to me that whenever there's a problem, you say, okay, well, how am I going to fix this, or how can I find a solution that is novel, innovative? And then I saw that you've been working on COVID and those who are immunosuppressed. You decide, well, I'm going to take that issue on. So how is that going? Because you experienced the
Yeah,
issue.
yeah. I mean, we figured out that you just have to redose, and sometimes you have to lower the immunosuppression a little bit of one of the drugs in order to get a good response. I mean, I don't know, sometimes I feel a little bit like Forrest Gump that I just like show up at the right time. And when something's happening and it sort of breaks my way. I can't explain the phenomenon that you just described other than I guess I'm very curious and I have if I have a talent, I have a good gut for like what's going to be important, like what's the next big thing. And it's oftentimes trying to solve a problem that, is somehow related to me.
Is did you ever get COVID, or you never
Yeah,
got COVID?
I did.
You did?
I did.
How'd you do
Yeah.
with that?
I was fine. I was I was again on one of these outdoors trips and I had no way of getting tested or anything until I came out of the woods. And I just, it was like a flu or something, really. I was fine, but I had already gotten the vaccine and I had, that third dose and had a response to the vaccine. So I wasn't that worried. I thought it would be fine, I think the people who really, the people who died, were often people in the high risk groups, but not only. And they were tended to be naive, their immune system naive to this new virus.
So you mentioned you came out of the woods. Were you in another country at that time, or just in the
Yeah,
United
I
States?
was in Spain. I was in Spain, in the middle of
So,
nowhere. Yeah.
so I just indulge me for a minute on this. I can't help but bringing this up because years ago, when we were talking about setting up the transplant program, that when I was a commissioner,
Right.
we had to set up at NYU. But I remember you had a rather distinguished mustache at that
I
time,
know. Yeah.
and that got me to thinking about something that I recently came across, which is there's actually a United States National Beard and Mustache Championship, and this is a true story. And at one point, they set the Guinness World Record for the longest chain, 195 feet long, and 86 people connected. But you made it into the Guinness Book of World Records for something way more important than your facial hair, right? And that was doing these domino kidney transplants. So maybe you could
Right.
tell us a little bit about how that came to pass, and more importantly, what is a domino kidney transplant, and how that has
Yeah.
changed the course of care.
So before I realized that where we really need to go is to find a completely different source of organs, I was trying to make these incremental improvements in what we had, which was human organs, in this paradigm that somebody has to die for somebody else to live, with the exception of things like a certain percentage of kidney transplants that come from a living donor and a certain percentage of liver transplants. But so one of the things that I was working on was trying to really expand living donation. And I first became involved in this with two surgeons, Lloyd Ratner and Lou Cavusi, when I was a fellow. And we were working on developing this new procedure using minimally invasive techniques for the donor, because the kidney donor operation used to be like way bigger than the recipient operation. And the recipients would go home, from the hospital before their donors. They'd have these big incisions. You'd have to remove the 12th rib. And so we used, these new, this was back in the mid 90s, new techniques, minimally invasive techniques, and developed this new operation to make it easier for people to donate so more people would donate. So there happened to be a woman who was listening to one of these lectures that Lloyd Ratner was giving about this new operation. And she was connected with the transplant world, but on the side of the groups that procure the organs. And so she didn't know anyone who needed a transplant, but she decided when she saw that it was easier, less impact to donate, she said, I'm going to donate my kidney. And she came to Hopkins and said, I'm going to donate my kidney to anybody who needs it. This was in 1998. No one had ever done that. We had to go through all these, ethical discussions and everything. So she did, and she also, brought a publicist with her because she really wanted to start a revolution. And the next day, 50 people called and said, all right, we want to donate our kidneys just like that lady. So we gave her kidney to a child because they're really impacted um, by kidney failure. And then over the next year, we transplanted all the children on our list with these kidneys from altruistic donors. And so at the time I was working on this new idea of how to help these people who had a living donor, and this is 30% of the people, but their donor was incompatible, either because of their blood type or their tissue. And what we would do is, we would say, okay, well, you guys are incompatible. Do you have another donor? And most people don't have another donor. And then it was, okay, well, you have to get on the deceased donor list and wait, years. And so we were trying to, remove the antibodies that cause that incompatibility. But then it occurred to us, well, we could have one of these altruistic donors give their kidney to somebody who has an incompatible donor, and then that person could give their kidney to the person at the top of the list. But if you think about it, you could go through many iterations of that, and that's how the domino transplant happened. We did the first one. It got a fair amount of attention, but we never thought it would be that big a deal. But then a guy picked it up who was an executive thinker and who was a businessman, and his daughter needed a kidney and he was incompatible. And his name is Garrett Hill. And he turned it into this gigantic thing. And it's a national registry now. And guess what? We've done 10,000 of these transplants. Now, to answer your question about in the very beginning, we thought we had to do them all on the same day in the same operating rooms so that somebody wouldn't renege, right? And pull out. And so then, we were able to really justify that even if that happened, it would be okay because no one would have given their donor's kidney away before they received it, if you think about it, with these altruistic donors. But during one of those, we did a big swap, 10 kidney transplants, 10 donors, 10 recipients, and that's what got into the Guinness Book of World Records. So sorry for that long description.
No,
That's
great.
what it was.
Great information for us to share. But then so basically what you're saying is that this helps increase the amount of people who receive a kidney transplant. And yet that's one way of doing it, but you've also taken on the innovative field of doing a pig to human kidney
Yes.
transplant. I thought maybe you could talk a little bit about that
Yeah.
groundbreaking
So
research.
the idea was, guess what? We did these kind of nice innovations to try to increase living donation. But then one day I was looking at the statistics, the national data, and I realized that over the last 2 decades, living donation hasn't increased in size, even though we did these transplants that wouldn't have happened, 10,000 of them. Something else shrunk, it was for me, it was a moment of reckoning, like, okay, even if we had a magic wand, we could make all these changes in our system and everything that are being talked about now. We still wouldn't have enough organs, not nearly enough. So that's when I really my brain locked on to this idea of, you know, xenotransplantation, using organs from another species to solve the organ crisis, bioartificial organs, basically 3D printing or creating organs in the lab. This is the future. And then I've just been chasing that, for the last 8 years. And in 2001, we did something very unusual that we had to talk to the Department of Health. You would have been involved in this if at that point you were still in your previous job. And we, the problem was the FDA just didn't seem to be open to the risks that might be involved in using a gene-edited pig organ and transplanting it into a living human. It's a big jump, I have to agree. And then there's this concern about what's called zoonosis, or and all about this, is the risk, of creating another, like COVID or something like that, another pandemic. We think that risk is very small, by the way, and we have great surveillance platforms to minimize that. But still, we couldn't get these organs into humans, so all the research was being done in primates receiving gene-edited pig organ. So we and others came up with this idea that we would test these in brain-dead humans who had been declared, when you're declared brain dead, you're dead. But frequently your heart's still beating, you're on a ventilator. Like these are the people who donate organs, right? But there's a percentage of those folks whose organs aren't suitable for transplantation. And so rather than just saying to the family, we're very sorry, we know your loved one wanted to donate their organs, but, you know, there's no recipient for those organs. Now we can say the same, like we're sorry about not being able to be a donor, but there is this other pathway. Your loved one, could um, donate their entire body for the purposes of testing these organs. And that's what we did. And we did the first one in September of 2001. We've done a total of 6. And initially, we could only study the organs for a few days. And then we got permission to do it for 2 months. And we learned a tremendous amount about the immunology, about the physiology. Do these organs completely recapitulate everything that a human organ does or not? We were able to answer all these questions. Then we went back to the FDA with all this great information and also screening to make sure that there weren't any infections. And they said yes to what is called a compassionate use transplant, where we were able to do this, uh, you know, transplant a gene edited pig organ into a living human who was very sick, who had no other option, didn't really have much time left, on death's door, basically, to try to extend their lives and give some palliation. So that's how that all started. And now we're at a point where we're about to start a clinical trial because, the FDA feels this is very promising.
Well, what happened, even though I don't want to go into patient care, is just in general, what happened that then that didn't worked, but then you ended up sort of saying we're going to have to remove the kidney.
Oh
The
yeah. So our most
victim.
recent patient, who, Tawana Looney, who's, she has, waived her confidentiality. She's been a huge advocate. She's a courageous champion of xenotransplantation, and she. Um, so there's a very small percentage of people who donate a kidney who end up getting renal failure. It's very small, but she was one of them. So she donated a kidney to her mom in 1999, and then she had preeclampsia during pregnancies, and she developed renal failure. And as a result, she also, this is how my life gets all intertwined, she developed those antibodies that prevented her from getting a match. So she was very hard to match. We call that being sensitized. And she was sensitized to almost every human, in the population. She would be predicted mathematically to get one kidney offer every 10 years. She waited 9 years on dialysis, no offers. And she was starting to have problems. We were having trouble getting dialysis access, to blood vessels. And she said, I want to do this. She sought us out and said, so she did great for, over 4 months. And she had an infection, which I think, probably triggered her immune system. And then, it was at a time when, we could see that some of the uh, parts of the immune system were like really kind of recovering, and because of the infection we had to lower immunosuppression a little bit, kind of a perfect storm. And she developed a significant rejection, and we were worried, she was worried about throwing more immunosuppression, and we wanted her to be able to have options in the future, so we decided together to take the kidney out.
A question: when things don't go correctly, and we've seen challenges like with Jesse Gelsinger back in 1999 when they were
Yeah.
doing therapy and other things, even when there was challenges, in space program early on in the 60s, right? And then people keep pushing forward. How do you make sure people don't become risk adverse? Because you're not risk adverse, clearly, given where you've gone and what you've done. People would have stayed in their living room and not gone to Patagonia. So I'm just trying to wonder, how would you address that?
Yeah, so I'm, I'm willing to take reasonable risks, thoughtful risks, with a lot of information, with a lot of data, with a lot of, you know, uh, ethical oversight and, doing it the right way. I mean, you and I work together. I think you have an idea of, how important I think it is that when we're doing big, important things like this, that, you have to do them well, and you have to, be like quality, safety, though they have to carry the day. But we shouldn't shy away from these big challenges. I mean, because I feel this is what I feel in my heart. It's unacceptable that we have somehow rationalized and normalized the idea that we have something that really works, organ transplantation, that we only offer to 3 or 4% of the people who need it every year. And we don't keep track. We keep track of the people who die waiting on the list, which is, roughly, like I said, only a third of the people on the list ever get a transplant. The other ones get too sick or die. But what about that 90%? That 90% that never makes it on the list. We never hear about them. They die. I think we should be just as responsible to them as we are to the subjects of these trials, right? I mean, so, the idea that there are acts of commission, you do a xenotransplant, yes, that patient, you have to shepherd that patient through, make sure they do well, make sure this is safe. But you should also take responsibility for the people who never have an opportunity to get a transplant. And that's what we failed to do. And people don't think about that. I think about it. I ask my team to think about it. And I think that's what drives us on. It is we can't just forget about 90% of the people. We need to get a solution for them.
And that's really leadership in medical leadership in so many ways, and being innovative. I know there are questions in the audience, but I wanted to ask you a little bit about your trip to the Ukraine, because here you are
Sure.
with heart transplant, all these other issues, and you put yourself right into the middle of a war-torn area to help people, again, about leadership. So maybe you could share a little bit about what that was like.
Yeah, so I don't have any connection to Ukraine, other than sitting in my living room and just looking at the television, just couldn't believe what was happening. You know, i- in modern times, I'd never seen in my lifetime, with the exception of 9/11, I'd never seen anything where the difference between wrong and right was just so clear. You know, here you have this country that is invaded by a bully, and and the people, rise up and do what they can to try to save their own lives. And I, I truly um, felt, it was a moral imperative that I get involved, and not just like by saying good things about it and supporting it, but directly involved. And I felt very strongly about that. So, I tried initially. I have a good long-term friend who's a transplant nephrologist who's Polish, and I asked him if I could come over and help with the 3 million people that crossed the border into Poland, who I'm sure many of them needed a transplant. And he said, well, let's try to like start talking to some of the transplant centers. I don't think they're doing any transplants right now in Ukraine, and we could help screen patients, these patients who are going to die if they don't get a transplant very soon, who have failed dialysis or need a liver transplant. And so we started to do that, but before the low-level satellites, um, the Russians were blocking the internet, and so we couldn't really ever get a good Zoom meeting off the ground. And at the end of one of these, the group, transplant surgeons from Lviv, said, "Well, I know this would be impossible, but if you really want to help us, come and help us. Like this is not working." And what can you say to that? Um, But so yeah, it was, in the beginning they told me don't tell anybody you're coming because you'll be targeted, and so when I went over, I didn't tell anybody except I told my wife 2 hours before I left because I didn't want her to talk me out of it.
Now, what did she say?
She was pretty upset, but she was she's been all through all of this with me, and she just said, you follow a different you know pattern in life, and I'm just going to believe that you're doing the thing that's right for you. So we went over and we had to get across the border. That was chaotic and crazy that first time. Now I've been there 4 times, and I feel like we really made a difference, and not only in helping, and getting some of these transplants done that were really life saving, but also when I came back from the first trip, I was able in New York through the Greater New York Hospital Association and Live on New York, their foundation raised $300,000, and I took over all this operating room equipment, headlights, all these things. They lose their electricity and it's crazy stuff, and that made a huge difference too, I think. So I just I feel terrible about where we are right now, but I'm still hopeful that there's going to be a solution that is going to honor these incredible people who are just trying to protect their families and their homes.
Health has no borders, and so people just want to take care of those who are dear to them, which goes back to a little bit of a question I wanted to ask you about relatives, and back to the cardiac issue.
Yeah,
So were your relatives with you when some of these arrests happened? And what about your family?
yeah. My
What
kids,
aren't they concerned about some of this for
sure, yeah.
themselves?
My oldest son did CPR on me in Patagonia the second time when I went into that coma for a month. And I can't even imagine what that was like for him. Um,
So I will
and
just. I'm sorry. Go ahead. Go ahead.
and yeah, my kids have inherited it, and they have defibrillators. And we're waiting for that. I think CRISPR is probably going to be the technology that is going to change things. In our family trajectory, um, because it is we know what the gene is. It's one of the building blocks, in the genetic code. I tell people it's like if you had, nobody knows what a phone book is anymore, but like the old yellow pages, like one number in there is wrong, and it's only wrong by one digit, and yet it has such huge consequences. And that's what our genetic disease is. And so I think it can be fixed. I think, CRISPR can go in and take that one number out and put the right number in.
Well, I
So
will tell you that my father's a personal story. My father and I were sitting, and my brother was sitting behind me at Rosh Hashanah services, and he arrested right there. And my
really,
brother, who my brother's a heart transplant
yes, I
cardiologist,
do know your
and he,
brother.
right,
Yes.
right, and he did CPR on my dad to get him back,
Wow.
and so that feeling and just seeing your relative collapse right in front of you is really
Yeah.
is
Yeah.
a shocking situation. So
I should get your brother together with my son because I don't know if he's ever talked to anybody about
yeah,
that
doing that.
experience. But
Yeah,
yeah.
so it was pretty fast, but still, it's like
Yeah.
a shocking
Profound.
experience. It is very profound. We have, I could talk to you for another 2 hours or longer, but I know there are questions out there, and this is the time when we turn to our most important guests, in the sense our subscribers who are out there. And I know that Adora is going to tee up the questions for that. I'm sure there's a lot that they want to ask you. And as we do this, I always mention that the podcast is for informational purposes because it's not in the place of a doctor's visit, even though you're talking to a superstar doctor, because your own doctor knows your own medical conditions, so you should talk to them about things. But
Sure.
let's hear what questions are out there right now.
We have Joe Allen who's going to come on. His camera's on. He is unmuted. I'm going to spotlight, and he has two questions he would like to ask.
Joe, what's up?
Joe, we can't hear you.
I'm so sorry. Thank you so much. This has been incredible conversation, and I remember reading an article last year about the man that received the pig lung transplant, and so that was just really incredible to hear. What you kind of touched on this, but in terms of other of using things outside of just human transplants, I would love to hear what your thoughts are on 3D printed organs and
Yeah.
the future of that, and is that a viable option in the next few years, and then where does that lead to in terms of other things that we can do with 3D printing semi-organic compounds?
Yeah, great question. I think it's kind of a three-legged race right now between bioartificial organs. These organs that you can take like an animal organ and decellularize it, and then put human stem cells down, on that scaffolding, and coax them down different pathways and recreate an organ, right? Or you can actually 3D print, an organ, and again create the scaffolding and put stem cells in there. But the beautiful future of that is you could have somebody who was like in CKD stage 3 or 4, so not right in need of a transplant, but will need a transplant in the next couple of years, and take some of their stem cells from maybe fatty tissue and make a designer organ for them, and they wouldn't need immunosuppression, right? Because it would be their own tissue. Mm-hmm. So that's where this thing, I think, is ultimately going to go. Then the other thing for like hearts, they now have a fully implantable, this sort of floating magnet heart that works way better than any of the previous artificial hearts, and that is showing some promise. We're about to start a clinical trial here using that new heart, and then xenotransplantation. I think some point in the future we're going to have all these things going at the same time, and we're going to be able to look at different patients, their individual situations, and say, you would be best, to receive a pig organ, or it would be best for you to try one of these bioartificial organs, or, you're 20 years old, the gold standard is a human organ, so we're going to reserve those human organs that we do have for someone like you, and that's going to give the best possible outcome, because that person's probably going to need several transplants in their lifetime. So I think that's what I envision in the future.
Joe, did you have another question?
No, that's all. I mean, I'm actually fascinated by the notion of taking someone's existing stem cells and then using that to create a custom organ that would not have to be you wouldn't have to be immunosuppressed in order to receive, because for all intents and purposes, it's part of you.
Exactly.
Anecdotally, I had a friend in college who unfortunately had suffered a brain hemorrhage during pregnancy. They had to remove part of her skull in order to relieve pressure, and when they did that, they stored it inside of her stomach.
Yeah.
And I was just fascinated, because your body's not going to reject part of itself.
Right.
And then eventually they were able to put it back in. She made a full recovery. It was incredible. But wow, just continue to be fascinated by that level of medical technology. So thank you.
Yeah, that's a great little trick.
Mm-hmm. Thank you so much, Joe, for your questions. That was absolutely amazing. I would like to ask our next person on, Anna, who is ready to ask her amazing questions.
Hi. Wow. I do want to say, I agree. All of this has been so fascinating and honestly a little surreal. So it's just incredible what you're accomplishing, Dr. Montgomery, and also being a patient as well. My question is about, some transplant patients or recipients have shared stories of like new feelings, habits, or even dreams after receiving an organ. As a patient yourself, what's your take on those experiences? And do you think that there's any truth to the idea that parts of who we are live beyond the brain?
Yeah, so look, I've gobbled up all those articles, that I can find on that phenomenon, and I think it's a real phenomenon. I personally don't have anything quite like that, except that what's very clear is that when I woke up from my transplant, I really felt like I was guided, and things were just so clear in my mind, like what are the next steps that I need to do to make xenotransplantation, a reality. And I think I busted out, after that, in a way, that I don't think people would have predicted we'd be where we are right now, starting clinical trials. 3 or 4 years ago, it's really accelerated, and I think, I don't know how that fits into this paradigm that you're talking about, but things just seem so clear to me about how I felt we needed to,
That's beautiful.
do this. Yeah.
Yeah, that's awesome.
Thank you.
Yes. Thank you. Thank you. This has been a really great episode. Dr. Zucker, thank you.
It's a fascinating conversation about some of the things that Dr. Montgomery's been through, but also just the whole field. And it's so amazing how it all intertwines what your research is on, what you've been doing, how it basically helps save your life, and where it's going. So I'm thrilled. This is a great discussion. Dora, who else?
Yeah, we have one more. Guess we'll ask question. John, we're going to John. Welcome, John.
Thank you very much, Dr. Montgomery. Thank you for being here. This was amazing to hear about. It so happens, oddly enough, that this is the 2-year anniversary of a good friend of mine's death. She had gotten 2 heart transplants. The first when she was 24 years old. And she, had a second one and eventually died, not because her heart gave out, but because she developed cancer, because the immunosuppressant drugs.
Lung cancer?
Breast cancer in her case.
Breast cancer, yeah.
And she wrote a couple of books about her experience. She wrote a lot of op-ed pieces and all of that. She was very outspoken about the quality of life. Yeah. That she said, how is it that the first transplant was performed about 60 years ago, and basically the medicine for treating transplant recipients is sort of the same? Is that the case? And how has your quality of life been?
Yeah. So, my quality of life has been great, but there was I had to struggle with some of the side effects initially of the anti-rejection medications. And you're absolutely right. And your friend was absolutely right. For whatever reason, after there was a lot of interest by pharma in transplantation and in these drugs, there's been very little development of new drugs in the past 30 or 40 years. And, maybe it's because the results are quite good, but the impact on, lifestyle and the wellness, and the side effects have not been good. And you talk to any transplant patient, they will tell you about their personal challenges with these drugs. They're very powerful. They do have a lot of side effects. They keep us alive. They keep us alive, so we're grateful. B, we are the beneficiaries of somebody else's sacrifice and gift. And, in many cases that meant them dying. And so it's hard for us to develop a voice when we just feel grateful. But it doesn't mean that the quality of life is perfect. Now, the alternative is death, right? Or a very poor quality of life on dialysis. So we all feel we've been upgraded, but there's not enough attention to these long-term side effects. I'll just, in 2 seconds, tell you about the most exciting thing that I think we're doing in xenotransplantation is we take a piece of the thymus of the pig, and 2 weeks or 2 months before we remove the kidneys, we put that thymus underneath the capsule of the kidney. The thymus is where the immune system gets educated. And we try then to, when we transplant the kidney plus the thymus, re-educate the human immune system to not recognize that kidney as being foreign. And the idea is eventually we hope to be able to reduce the immunosuppression or come off completely. And guess what? It's showing a tremendous amount of promise. So, that's called tolerance. And so I'm hoping that through this, we maybe can also solve that problem that you're referring to.
That would be great. Yeah, my friend Amy Silverstein referred to it as the gratitude paradox, that people just expect you to be grateful to be alive, and they don't want to hear you complain about it.
Yeah, that's right. I know of Amy, and so I thought maybe that's who you were talking about.
Yeah, she was a force of nature, that's for sure.
Yes, she was.
Can I ask her? I don't know if it's directly related, but are there any, among any of the policies or ideas that RFK Jr. is floating, are there any that you think threaten either the current state, let alone the ability to keep pressing ahead in transplant science, or that threaten transplant recipients right now?
I mean, I haven't seen anything, at this point where, we're obviously going to be watching NIH funding really carefully, because that's what's really important for us to make these big advancements. So,
thank you very much.
Yeah,
John, I gather that Amy is the one who wrote the article in the New York Times. There was an article I once read, an op-ed that she wrote about a transplant. I actually have a question about, because John obviously has a friend who had 2 transplants, and I have a very good friend whose father had 2 transplants. And she always asks me this question, I thought I'd throw it out, about if there's such a shortage of donors, like, do you then give the second transplant to somebody else? And I mean, this is a tough ethical question. And I wonder, what your thought is about that.
Yeah. So, well, my thought is that, we should transplant anyone who's in need, and do it to the best of our ability. So, for me, I think, you've given the gift of life to somebody. They've done really well. I don't think that that's the right moment to throw in the towel just because that organ, is giving up. Frequently because we don't have, new drugs, immunosuppressive drugs. So I think, if they're a reasonable candidate, they should be allowed to have a second transplant or third transplant. Listen, I've done, in kidneys, 4th, 5th, 6th transplants on people. Now, frequently they're bringing living donors, along with them. And then you're sort of getting, something that's not affecting anyone else, right?
Well, it goes to the whole xenotransplant issue, right? If
yes, exactly. That exactly right.
We'll solve the problem. Dr. Montgomery, this has been an incredible story. I mean, both professionally and personally on your life. I am actually wearing, I usually don't wear red ties, but I'm wearing this tie because it's hard to see, but it's the Tin Man holding with a heart.
I see that, yeah.
Right, you see that? I felt it was fitting because your journey reminds me a little of the fictional story, but you're truly a real wizard in the world of medicine, what you've been doing. And you've helped so many people facing kidney failure, which is amazing. You've saved their lives. And at the same time, you've walked down that remarkable path, facing heart failure, transplant, ASCD device or devices and a transplant. And you continue to heal others, not just here in the United States, but overseas. And so I want to thank you for all you've done and all you continue to do, and for sharing your story with us today, because it's inspiring on every level. And I hope those who listen recognize that you just keep pushing, and you push whenever there's a challenge, or a hurdle, you just overcome it and keep moving forward. And so I thank you for that.
Yes.
And thank you very much. And that's our show.
Thank you. Thanks for those kind words. Yeah, there's nothing can replace grit, Yeah.
True, grit. But you keep traveling wherever you want to go. Spain, you just keep moving around the world. I guess you're right. You have a lot of lives, and just keep pushing them, and keep doing whatever you can to solve the world's problems that are out there in many ways, not just in clinical care. That is our show for today. Next time on Docology, we're going to hear from the former head of the Office of Migration and Quarantine at the CDC. And he's going to explain how bugs, viruses, bacteria, how they spread around the globe, how they end up on our shores, and what to do about it. But remember, if you're a Docology subscriber, you can join the show. You just have to click on the link in the bio. And so tune in next time, because the topic we cover may just save your life. Docology is a production of Hang Media. Our producer is Catherine Warren. Ronnie Selig is editorial advisor. Our creative director is Anna Richard. Janine Wilson of Wilson Media Group handles paid marketing. Our publicists are Leslie Ann Wade and Jerry Caracoli. Theme music was composed by Nick Kitts. Subscribe and join our community at docology.life. Until next time, move, wash your hands, and stay healthy.